we've got a limited amount of time, and I've got a lot of slides to go through, so hopefully you'll be able to get some of the handouts, which I think will be helpful. And really what I wanted to touch on is not so much any specific thing as much as sort of the nature and direction of where we're going in terms of Parkinson's research, how that impacts treatment, both symptomatic treatment and then hopefully, obviously, towards our ultimate goal of stopping the disease and curing it. Given our limited time, I'll probably skip over a number of slides and we'll probably hold off on questions till the end. But if you think of anything, please take note of it and hopefully we can get to it at the end here. So a little bit by the numbers. Parkinson's affects 1 million Americans, about 7 to 10 million worldwide, and probably both of those are underestimated, certainly from the worldwide estimate, just given the fact that there's limited healthcare access to large portions of the world. 60,000 new diagnoses each year just in the United States. So this is quite a really burdensome problem that, that affects society as a whole as well as families and individuals, and affects greater than 1% of people over the age of 60. And so as we've got better health care overall, we have people surviving and doing well over the age of 60, 70, 80, and we want to maximize their ability to function with and without Parkinson's. You can see, okay. And then men are 1.5 times more likely to develop Parkinson's than women for reasons that were not entirely clear. So Parkinson's, a little bit of background, I think that's familiar to most of you here, is a movement disorder characterized by slowing of movements, which is called bradykinesia, stiffness, which the particular type in Parkinson's is called rigidity, tremor, which is characterized by a resting tremor as opposed to many other types of tremor, which can be even more common, and postural instability, so balance problems, which may not be present early, but certainly can develop as the disease progresses. And then we know that there's a host of non-motor issues with Parkinson's. So it's not simply a matter of degeneration in certain parts of the brain, but really throughout the whole brain. So psychiatric, sleep problems, wake problems, lightheadedness, problems with controlling bowel or bladder function, and fatigue and weakness really being big issues. And so just a little schematic here, and I'll try to point. When we initially make a diagnosis of Parkinson's, we need to see a certain amount of degeneration in this part of the brain called the substantia nigra. Now, that's not where Parkinson's is solely localized to, but that's what sort of leads to the development of the classic features that we tend to associate with Parkinson's. And so when about 70 to 80% of those cells have degenerated, we start seeing the effects of Parkinson's. But really some symptoms can start well before this. Now this target, sort of this pathway here, where it is and where it projects to, are our main targets so far in treating Parkinson's and represent the vast majority of locations where we're trying to do research into either reversing that change or at least more effectively managing it. So the treatments are symptomatic, so decreasing the burden of the disease, knowing that we can't necessarily change the course of it. Neuroprotective, which is slowing down or maybe even stopping the disease progression. And then neurorestorative, which is really our ultimate goal, which is not just stopping the disease, but reversing it and curing it. So I'll start with symptomatic treatments. And the symptomatic treatments are really medication, pharmacological, and surgical. And then we'll get to the other targets. Just a little bit about drug development. It usually starts with preclinical studies, so looking at animals, looking at cells in culture in the laboratory, and then we move to phase 0 studies, which are healthy volunteers, small number, where we want to see, does this agent behave as we expect it to behave, or as it did in animals, also to make sure it's not toxic. And then we move on to phase 1, which is smaller, which is a larger group, but still small, still healthy volunteers, where we really are able to see how the agent is absorbed, measure levels of the agent through the blood, and determine what should be in a safe dose range. Then we get to phase 2, which is even larger, and this is where we start talking about people who have the disease in question, in our case, Parkinson's. Does the drug work? How well does it work? But the primary outcome is safety again. Is this safe? Is this tolerated? Are we using the right dose to determine those things? And then phase 3 are the ones that really get the most press, and they should. These are really large. These are multi-center sites, so not just at one location, but many locations, typically throughout the country or even the world. And they are blinded, meaning some people get an agent, some people, and they don't know what they get. Many people that are rating them don't know what the patients are getting, and there might even be a placebo-controlled phase of it. So the FDA requires 2 successful phase 3 studies in order to approve a new agent. And then phase 4 is post-marketing. So once a drug is approved, it's in the general population and used, are there any sort of delayed adverse effects that we didn't find in the phase 3? And I think a good example of that are things like Celebrex and other things where we notice that people at high risk of heart events, potentially, that might not be a safe agent in. So limitations to our current medical treatment, and again, this is probably not too unfamiliar to many of you, but medication continues to work, but the disease progresses. And the way the disease progresses limits our ability to find effective strategies to cope with it. There can be motor fluctuations where the medication just doesn't work as well, meaning it doesn't absorb as well, kick in as fast, last as long, or it can become unpredictable. And then there's symptoms that develop that aren't responsive to medication. Balance problems, walking problems, things like freezing, and potentially issues with memory and sort of motor and memory planning and planning of tasks, what we call executive functioning. So with motor fluctuations, again, wearing off, decreased time of effect, incomplete or delayed effect, and dyskinesias. Some ways that we can try mitigating those effects are to have different formulations of what we know is the most effective agent, which is the levodopa. The levodopa either in combination with carbidopa or on its own. The CERE formulation is good, especially early in the disease, but then it can fall, unfortunately, to the same pitfalls as the regular levodopa. So these are a few things that are at various stages of development. A new formulation of extended release carbidopa levodopa, an intestinal gel that's sort of pumped into the intestine, sort of like an insulin pump, but since the levodopa doesn't absorb through the subcutaneous tissue like insulin does, it would have to be straight to the small intestine. And then a gastroretentive cinnamate, so kind of like those foam animals that really puff up when they get wet, sort of something that develops kind of a gel form, stays in the stomach, and then slowly releases levodopa throughout the day. And then there's an inhaled form of levodopa as well that's being trialed. New drug targets, I think, really represent potentially a change in how we're managing Parkinson's, but it really remains to be determined whether these are things that can be used on their own versus in combination with what we have already. So there's different receptor targets here, and I won't go through them. Some of them that are currently being used in other medications approved for Parkinson's, and some of them that are brand new classes. And then there's surgical treatment. So people who respond to medications, but again, have these fluctuations. So we're trying to mimic the best effect of the medical treatment, but in a stable fashion, or at least a more stable fashion throughout the day, with the exception of tremor, where surgery can potentially have better benefit than the medication. Or there's side effects to the medication, nausea, lightheadedness, other issues, or where there's dyskinesias that limit people's ability to function, even when the medication is on. So limitations of surgical treatment: it doesn't slow or stop progression of Parkinson's, so it's really a symptomatic treatment. Most people still need Parkinson's medication after surgical treatment. And there's risks of surgery, so we have to balance what's our expected benefit with the risks that are there. And as with any treatment, there's no guarantee of benefit, and potentially in certain individuals, there can be a risk of worsening cognitive function, so we really want to make sure we're identifying the people who can get the best benefit with having the least amount of risk. And then it doesn't, unfortunately, improve balance issues. So that's a limitation which I think is important to keep in mind and sort of underscores kind of what our limitations are. Yes, absolutely. Sorry about that. So what are the benefits of surgical treatment? Well, we can improve quality of life by allowing more consistency through the day, right? So if medications work well, but they're not consistent, they're not reliable, that's interfering in and of itself. If we can at least provide some sort of basement effect, then that potentially can be helpful in and of itself. And with that, we can potentially, if not stop medications, at least lower the doses of medication. So if there's some side effects from those, we can hopefully try to avoid them. And then at UVA, we're experimenting with focused ultrasound, which is a way of making lesions in the brain that are non-incisional. So it's making an ablative lesion, not using stimulation, and we're using beams of ultrasound to heat up targets deep within the brain that are along certain pathways. So there's tremor pathways, there's Parkinson's pathways. If we interrupt those, then we can potentially improve or at least revert some function back to something that's closer to normal. And we're the first center to use this type of technology to treat patients with essential tremor, which is a different disease, but shares some features in terms of tremor with Parkinson's. And I'll go through sort of a side-by-side comparison of this versus what we already have that's FDA approved and available. Pallidotomy and thalamotomy are ways that we can make those same lesions. They've been used for decades, but they involve a burr hole to be placed in the skull and to go down into the deep territory. So that involves, again, no permanent hardware that's left in the brain, but that burr hole can sort of deter some people from going further with surgical treatment. And then the two targets that I have there, pallidotomy is good for a lot of the Parkinson's symptoms, slowness, stiffness, and tremor. And the thalamotomy only treats tremor. In terms of deep brain stimulation, and that's probably the most common surgical technique, not probably, definitely, where we're not making a lesion, but we're inserting electrodes and stimulating them, making an electrical field that interferes with these abnormal pathways. So since we're not making a lesion, it's technically reversible. We can do it on both sides with less risk of problems like swallowing or potentially speech problems, which I'll get into. And there can be a little bit of a honeymoon period with the deep brain stimulator. But I'll skip to this table here, which hopefully you'll be able to read in your slides as well. But it's sort of a side-by-side comparison of the surgical treatments we have available with focused ultrasound at the top there, and the pros being it's not incisional, it doesn't involve opening the skull, which I think is compelling for a number of people. We hope that that means there's less risk of infection, though we're doing studies to really show that that's the case. And it's a one-time procedure. The cons are it's experimental. Currently, we're only using it for tremor so far, though we expect to change that. It's only one-sided. That's because it's a lesion. We don't want to make lesions in multiple sites in the brain just because that increases the risk of side effects. And it's a one-time procedure, so while that's a good thing, it's also limited because what benefit we get is the benefit we're going to get. And if there's side effects, those are the side effects we'll see. People can recover function with time, but that's still an important consideration. With the traditional lesions, again, it's a one-time procedure and we're not leaving any hardware in the brain, so there's less risk of infection moving sort of into the chronic phase. But again, it's a one-sided treatment and it's irreversible. So we're stuck with what our shot is. In terms of the deep brain stimulator, we can sort of program it. We can program it to maximize benefits and minimize side effects, and it's reversible because we're not making any permanent lesions in the brain. And so since that's the case, we can treat both sides of the brain and therefore both sides of the body. The problems with that, or at least the cons are, there's hardware that remains in the brain and in the body itself, and so there can be risk of infection, there can be risk of trauma, and it'd have to be fairly significant trauma, but trauma nonetheless that potentially could fracture some of the wires. And then there's a battery. So the battery typically requires replacement every 5 to 10 years, and that's a consideration to keep in mind. And the programming, while it allows us a lot of flexibility, can be protracted in some cases. So these are considerations we have when we discuss with patients what are our optimal surgical treatments. Moving to the neuroprotective treatments, I'll start with exercise and then I'll move to some pharmacologic options, and I put an example there. But with exercise, this probably has the most evidence, aerobic exercise, of slowing progression of Parkinson's. We can't prove it because we can't take people's brains out of their head before they're done using them, but we can do that with animals. And so with animals, we've shown that animals that are put on a treadmill tend to do better than animals who aren't put on a treadmill. And the thought is that the brain sort of is a plastic organ. It can make changes. It can sort of, different parts of the brain can take on new function. And exercise and increased vascularity can help with that, so increased blood vessel formation. Maybe even growth factors are released, so things that can help the brain not only get more blood, but also make stronger connections between different regions, and then improve fitness. So just in general, for everyone's cardiovascular health, exercise is important, and that can have a positive impact on Parkinson's as well. So there have been some studies looking at ongoing vigorous exercise, and that it potentially has quite a nice effect in at least slowing Parkinson's compared to people who don't exercise. And then there's a number of different trials ranging from Argentine tango to playing the Nintendo Wii and things like that. And then moving on to pharmacologic treatment. So there's a whole host of things that have been studied to see if they potentially slow Parkinson's. I'll start with probably the biggest and the one that's gotten the most press, especially recently, is Rasagiline or Azilect. Now that's a symptomatic treatment for Parkinson's. It can improve symptoms, but there's also a thought, at least in the laboratory, that it can protect neurons or nerve cells from degeneration seen in Parkinson's. So there was one study, Adagio, which was about 1,200 patients, and they used a little bit of a complicated study design, saying we're going to take some people and we're going to split them in half and say half those people we're going to start on this medication, the other half we're not going to start on it, and then at a certain point we're going to put everyone on the medication. And if the medication just has a symptomatic benefit, then the amount of benefit from the people who started early versus later will eventually be the same. But if there's a protective benefit, then those people who were started earlier will keep doing better than the people who started later. And what they found is at the lower dose, they saw a trend towards that effect. Unfortunately, the higher dose, they didn't find that. So it didn't really make too much sense, and I think the jury's very much out on this. I think most of us aren't too optimistic that it can have that protective effect, and when they applied to the FDA, they didn't get an indication for protection in Parkinson's. But nevertheless, something that I always discuss with people and families is, this is what the results are, and we have a discussion if that's something that they really feel strongly about. Coenzyme Q10 is something that's ubiquitous at any Walgreens and CVS. There were studies in the past that showed that there might be, at very high doses, some benefit of using this in slowing Parkinson's. Unfortunately, in the largest, most recent study, which was done in New Zealand, they found that it was stopped early, unfortunately, because they didn't show that protective benefit. But the theory behind it, that it helps protect the energy-making parts of the cells, which we know are dysfunctional in Parkinson's. There are other compounds that are part of that are being investigated and potentially may offer some more benefit than the coenzyme Q10 did. There's a few other studies that are sort of coming up or ongoing with different agents. So at various stages of sort of those phase trials, phase 2 or 3 trials that we discussed earlier. And so I'll skip over the particulars, but they're all in the slides. And then I'll just really briefly touch on nicotine. Sort of cigarette smoking is associated with a decreased risk of developing Parkinson's. Now we don't know, is that really the nicotine or something in the cigarettes, or is it sort of people's personalities that may have Parkinson's really well before, decades before the symptoms start that leads to it. But in the laboratory, nicotine potentially can have some beneficial effects. Now, a lot of things are promising in the lab that don't end up panning out in people. So I think it's important to keep a little bit of pragmatism here, and I don't want anyone to start smoking if you don't. But there are trials that are looking at sort of the nicotine patch and other forms of nicotine to see if it potentially can slow progression of Parkinson's. And then a number of other agents, some of which are oral agents, some of which are not, that are being investigated. And then moving on to the neurorestorative treatments, stem cells and neurotrophic factors. Neurotrophic factors meaning things that help the brain or induce the brain to grow. Stem cells originally, or at least with the first studies with Parkinson's where we're looking at patients, were fetal stem cells that were implanted into the brains of people, so kind of at the end of that pathway, not at the substantia nigra part that degenerates, but where they project to. deep in the brain called the putamen. One of the studies that got the most press looked at 34 patients and followed them for 2 years. And what they found is no significant improvement in the patients who got the transplants versus those who didn't. The ones who had a sort of a higher dose, got cells from more donors, had a trend of doing better, but it really wasn't compelling enough for the investigators to go forward with that study. I think even more unnerving with that is more than half of the patients who got the transplant developed dyskinesias even without any medication on board. And exactly why that happened, we don't know. But I think that that's certainly an adverse effect that we don't want to repeat. Even if those dyskinesias weren't necessarily disabling, that's not really something we want to see. And then 14 years after transplant, the autopsy of some patients showed that the grafted cells had developed Parkinson's-like changes. So really, this kind of spelled the end of using fetal stem cell transplants into the brain. And I think that was good to sort of stop at that point. But what is the role of stem cells now? Well, one thing that's been helpful is the ability of scientists to make stem cells without using fetal cells has really improved. So our ability to make stem cells that have the ability to differentiate into nerve cells, brain cells, we can now develop from things as ubiquitous as skin cells or blood cells from any adult, which I think really bypasses a lot of ethical issues, but also allows for us to potentially even make stem cells from Parkinson's patients themselves and study those. But I think the biggest role of stem cells now, and really I think this is the most helpful, is understanding what happens in Parkinson's. We still don't really know why cells degenerate and die. So if we can really mirror that process in the laboratory, then we can really see, well, what stops that? Or what can we do to potentially slow that process or reverse it, and then start moving towards applying that to people who are living outside of the lab. And then there's other factors, so implanting enzymes and growth factors into the deep part of the brain that sort of stimulate more of this production of these neurotransmitters that are deficient, particularly dopamine in the brain. We can inject growth factors into parts of the brain that can stimulate the nerves to grow. And the idea is that if we target areas that we want the nerve pathways to get to and inject a growth factor, then the areas of Parkinson's that degenerate will in fact regrow and reach out to those growth factors. And so the target is this area called the putamen, again, where those substantia nigra cells project to. And 2 growth factors have been studied extensively, GDNF and Neurturin. The names aren't terribly important other than knowing that they're sort of growth factors in the brain. Some initial studies with GDNF in animals and humans tried to infuse it into the fluid-filled spaces of the brain, not directly into the target nucleus, and they didn't really show much benefit. And really targeting the area where we're interested in was done later, still didn't show much benefit, but then again on autopsy we didn't find as much sort of spread of the agent as we wanted to see. So there's limitations in the technique that obscure our ability to tell if there's limitations in the actual treatment itself. But that's being addressed in future studies, and Neurturin is the one that really is being used more extensively right now, at least, in Parkinson's. So this is not directly injecting this growth factor, it's actually implanting it into an empty virus and injecting that virus into the brain and letting the virus go from cell to cell, essentially, and spread that DNA. So none of the viral DNA, nothing that should make us sick, but something that should spread this growth factor and then hopefully cause the cells where it sort of infects, not technically infects, to make this growth factor. So there was a randomized study where there was this Neurturin or this viral vehicle delivered into the putamen, and what they found is that there wasn't much benefit, but there wasn't much spread of the growth factor. And so, and with side effects, there was headache, there was a brain tumor in one patient, but looking back, that brain tumor was present before the study even started. So at least from a safety standpoint, the authors of the study said that we think it's safe, we just have to make sure we can try to see if it's more effective. So with these growth factors, sort of the unanswered questions are we using the right dose? Are we injecting the right places? Do we need to follow people longer? These are growth factors, and it's hard to do studies that last more than a year or 2 years. It's expensive, it's cumbersome, it's difficult for patients to get in, but it might just be that we need to follow people longer. And these concerns are being addressed in future studies with the Neurturin growth factor. So in summary, the future of Parkinson's research is really three-pronged. Better management of symptoms, so that we're improving day-to-day life of people with Parkinson's, but that's not the goal by any means. I don't think anyone in the room wants to have their disease managed. They want to have their disease gone. So we're trying to find ways of slowing down Parkinson's progression and then to really, hopefully, reverse it and cure it. The limitations to these goals are we don't know what causes Parkinson's, and I think that's the biggest thing. Infectious diseases, strep throat, we know what causes it. We know what bacteria causes it. We can grow the bacteria in the lab. We can try testing antibiotics. With Parkinson's and the brain in general, it's really a different subject. And we don't have good animal models because, again, the thing that separates us from most animals is not our kidneys or our heart, it's our brain. So things that can work in animals don't necessarily work as well in humans. And we don't have objective ways of testing for Parkinson's. We have our clinical ways, or clinical exam, but that can fluctuate. There can be good days and bad days, and if we catch a bad day or a good day, we might get a trend of something that really isn't accurate. So trying to find ways of following Parkinson's progression in an objective way by a lab test or by looking at an imaging finding, that way we can know if we're trying to make an effect or have an effect on the disease, we can measure that effect. So those limitations are slowly fading. We're learning more about Parkinson's disease, what causes it. I think a lot of it has to do with the fact that, with technology, we can collaborate over great distances, not just throughout the country, but the world, instantaneously. Share data, share preclinical data, patient data, genetics, pathology, things like that. And hopefully this will lead to better models of Parkinson's in the lab. And then research into markers of disease is a really hot topic. So trying to find ways of measuring the disease by things as simple as a blood test, hopefully. So while the horizons of Parkinson's treatment are promising, it's important to keep in mind that sometimes revolutionary advances happen out of nowhere, come out of nowhere. So while we have to be pragmatic, it's important to maintain a sense of optimism that even though things aren't necessarily on the horizon, something can hopefully pop up that comes out of left field and we're not expecting it. And that's what we're always hoping for, like penicillin. So if you want to find out any information on trials, and this is in the handout, you can contact us at UVA or through the APDA. And Susan Dietrich is the liaison of our APDA referral center. There's the web link to the focused ultrasound study, and then the Michael J. Fox Foundation and clinicaltrials.gov are very helpful resources. Unfortunately, the clinicaltrials.gov is not being updated during the shutdown. But this is what it looks like, and I don't know if you can read here, but I did a search of Parkinson's disease Virginia, and it returned 51 studies in various states are recruiting or completed, and so this is updated pretty regularly, and I'd encourage all of you to check it out. Because it's not, in this day and age, it's not possible for all of us to stay on top of every study that's going on. And then the Fox Trial Finder takes a little bit of a different approach. They have you register and then they contact people if there's a study that may fit for them. So this is our UVA Parkinson's team. Hopefully people that some of you have met. And I have a picture of Susan. Unfortunately, I wasn't able to upload it to this one. And there's Susan's phone number as well. So thank you, and hopefully I've left a little bit of time for questions. Yes?
Earlier, when you were talking about limitations to current medical treatment, you mentioned Celebrex, and I missed what.
Celebrex is not a Parkinson's medication. I was just sort of using that as an example of something that went through phase 3 studies and was shown to be safe and effective, and then when it got out into the public, then we started saying, hey, a lot of people on this are having, coronary events. Why is this happening? And that was an example of where sort of phase 4 monitoring was helpful in determining safety. That's a very good question. The question was, what dose of coenzyme Q10 would I recommend? And that's a very good question. And I'll say, if it's for Parkinson's, slowing down Parkinson's or treating Parkinson's, I'd say there's not really good evidence that any dose is effective. And I think that's important because coenzyme Q10 is not an inexpensive medication. You know, those studies earlier showed doses over 1,000 milligrams may be helpful. And I think most of the tablets are something like 10 or 20 milligrams. So it's a handful of expensive tablets that now we know don't necessarily make a difference in the Parkinson's. I will say a lot of people come in saying, you know, if I take coenzyme Q10, I feel better, I feel more energetic. And in that situation, I don't really think there's a high dose or there's a particular dose that I'd say. But I think, you know, it's safe, so it'd be worth trying for that benefit. But really anything like 10 or 20 or whatever is helpful for any person would be more than sufficient. And I don't think going over that would be any more helpful.